afternoon. My name is Cara Melmid, and I will be sharing with you my CBI today. Let's go take a look.
Hopefully my YouTube video doesn't disrupt the flow of today's CBI. I'll be talking about mesenteric blood flow, starting with a review of the anatomy and then going into more detail of the actual flow. The blood supplied to the large intestine originates in the superior and inferior mesenteric arteries. Here you can see the superior mesenteric arteries. In the midgut, we have the SMA, which arises from the abdominal aorta. The anterior and posterior inferior pancreaticoduodenal arteries anastomose with anterior and posterior superior pancreaticoduodenal arteries from the celiac trunk. The jejunal and ileal arteries also come off the SMA, forming anastomosing arcades that terminate in straight arteries, or the vasa recta. The colic arteries contribute to the marginal artery, and you'll see the middle colic artery, right colic artery, and ileocolic artery. The hindgut is supplied by the IMA. This also arises from the abdominal aorta and branches into the left colic artery, the sigmoid arteries, and the superior rectal artery. The midgut and hindgut are drained by the superior mesenteric vein and the inferior mesenteric vein. The superior mesenteric vein, which drains the midgut, has tributaries that are usually parallel with the branches of the SMA. This joins with the splenic vein to form the portal vein. The hindgut drains to the inferior mesenteric vein. Here, tributaries generally parallel the branches of the IMA. This typically empties into the splenic vein posterior to the pancreatic body. There are plenty of portal caval anastomoses. Here, portal tributaries that drain the colon communicate with the veins of the IVC, providing alternative routes just in case of portal hypertension. Okay, now let's get a little more detailed. The SMA comes off the abdominal aorta and supplies the midgut, like I said, by giving off the inferior pancreaticoduodenal artery and the middle colic, right colic, and jejunal and ileal branches. The inferior pancreaticoduodenal artery gives rise to the corresponding branches that anastomose with the superior counterparts from the celiac. The communication is again another important communication that helps maintain bowel perfusion in times of ischemia of the mesenteric vessels. The ileocolic artery supplies the ileum, cecum, and ascending colon, and the middle colic artery supplies the transverse colon and communicates with the inferior mesenteric artery. The right colic artery typically branches at the same level as the middle colic artery. The right and middle colic arteries are important suppliers of blood to the marginal artery and give rise to the terminal vasa recta. Now, the inferior mesenteric artery is the smallest mesenteric vessel and comes off the anterior aorta, providing blood to the distal transverse, descending, and sigmoid colon and the rectum. Again, many communications exist within the mesentery to the SMA, and rectal branches offer communication to the visceral blood supply with the common blood supply. The area near the splenic flexure is poorly developed due to poor arterial flow, and this is thought to be the most susceptible place to ischemia. Because of the multiple anastomoses in the mesenteric system, at least 2 of the 3 vessels must be occluded to produce chronic ischemia. Got that? Now let's talk about the etiology of mesenteric ischemia. This can be from arterial compromise, such as from an embolism, responsible for about 50% of acute mesenteric ischemic events, usually originating from a left-sided heart thrombus or from spontaneous or iatrogenic rupture and embolization from an aortic atherosclerotic plaque or aneurysm. Thrombosis could be accountable for 15 to 20% of acute mesenteric ischemia, resulting from thrombus occurring as a progression of atherosclerosis at the origin of the superior mesenteric artery. Vasculitis can also cause this condition, such as from rheumatoid arthritis, polyarteriosis nodosa, systemic lupus erythematosus, dermatomyositis, Takotsu arteriitis, and thromboangiitis obliterans can all result in ischemia of the bowel. External compression is pretty rare. A venous compromise can be due to venous thrombosis, which accounts for only about 5% of the cases. It usually involves a superior mesenteric vein and is associated with cirrhosis or portal hypertension. Other potential associations include inheritable hypercoagulable states, pancreatitis, malignancy, oral contraceptive use, recent surgery. Hypoperfusion, or non-occlusive ischemia accounts for about 20 to 30% of cases. Shock could be from any etiology and cause that hypoperfusion. Prominent causes include heart failure, dialysis, or could even be drug-related. It could be caused from a recent surgery, an infection, or other conditions such as pancreatitis, polycythemia vera, pheochromocytoma, or even carcinoid syndrome.
Thanks for listening. If you have any questions, you can email me at kara.malmid@gmail.com. Thanks.
There were also lots of slides taken from Dr. Fisher's anatomy and radiology classes.